Hello, everybody. It's a pleasure for me being here among you, and thank you for APT Medical and the MLCTO for preparing this meeting. Um, to be honest, it's not much time. We have the Elong microcatheters in our cath lab. We have more history with the balloons, Conqueror balloons, CTO balloons, and I'm sharing with you 3 cases here with my experience with the APT medical products. This is where I came from. This is our hospital, a tertiary center located in Shiraz, southern Iran, and these are the things our city are famous for: the Persepolis and the color dancing of mosque over there. Uh, the first case I'm going to present here is a very recent case I've done 3 weeks ago. She was an 82-year-old woman with a complex history of cardiac disease. She had been undergone CABG 30 years ago and a PCI on SVG 7 years ago. She had presented with persistent low threshold angina and dyspnea for 6 weeks, and she was a known case of hypertension and chronic renal failure with a creatinine, serum creatinine level of 3.3, which was stable over the past 3 years under my follow-up. Her ejection fraction was 40%, and because of the renal failure, we first performed a stress myocardial perfusion imaging, which showed a moderate to severe ischemia of the anterior wall. So we prepared her for hemodialysis and did 1 round of hemodialysis and went for the coronary angiography, which is shown here. As you can see, coronary arteries are severely calcified, and left main has severe stenosis. LAD is cut off, also L6 is cut off. And you can appreciate the calcification even before the injection of the contrast medium. This is Lima to LAD with very significant lesion at the anastomosis site. And in various projections, you can appreciate a severe calcified lesion after the anastomosis in LAD. It's another view of Lima to LAD. And she had a patent SVG to RCA, and the other SVG, which was stented 7 years ago with a patent stent in SVG to OM. It was a dilemma for us how to treat the patient. We consulted the patient with our colleagues in the heart team, and they suggested to wait for another 1 week for the full anti-ischemic medications, as you said. And she was highly symptomatic. She couldn't step out of her bed. So we decided to go for PCI because reduced CABG was not an option here, if you agree. And the dilemma was here to PCI LAD via Lima or PCI on left main LAD. We decided to go for the second option, actually, because the real fear was during the wiring of LAD via Lima, the flow was compromised or became compromised, and the patient with this unstable condition may aggravate somehow. So we started to go for the PCI from the left main. This is an extra backup catheter from femoral access, and we had a left radial access to visualize the distal vessel. We started to navigate through the CTO with Xeon Black. It didn't pass. We exchanged it for Gaia Next, and Gaia Next finally after half an hour passed through the severe calcification. However, this is when Gaia Next passes to the distal LAD. However, we couldn't manage to pass any of the microcatheters we had. We started with Turnpike, it didn't pass, Turnpike Spiral, and then we tried Elong, it didn't pass either. And then we started to a balloon from the proximal to see what happens. According to this diagram, the famous diagram of shown by Dr. Birlakis in his handbook of CTO, we go when we couldn't pass the microcatheters, we go for granuloplasty, and we put the sound black at first beside the Gaia next, and we started to balloon cutting wire technique, and then we started the granuloplasty. We ruptured almost 17 balloons, I guess, with all the sizes from Sapphire 110, 112, 115 helix. And the surprising thing was that we used Conqueror 1.6 and 1.9 and 1.12, and it was really hard to rupture the Conqueror balloons. We went very high pressure to rupture it, and from the proximal part, we have the most difficulty to pass our balloons. And finally, we managed to pass the first calcified lesion at the proximal part, and we pass another guideliner in the LAD and continue to rupture our balloons. And this is what our efforts led to. We could, after 2 hours, manage to millimeter by millimeter advance into the LAD, and I have one projection showing the balloon coming down the vessel. And because of the creatinine level, we had very limited injections. This is the final angio after preparing the vessel. As you see here, we have a good prepared LAD. Given the very heavily calcified vessel, we used the grip balloon, the cutting balloon. And from distal to proximal, this is the distal part of the LAD. We used DEB, and then we started to pass Orsiro here. It's Orsiro 2.540. And another Orsiro in the proximal part, and finally the ostial left main. This is our final results. And the interesting thing was we had no problem with the patient's hemodynamic during the first 2 hours of the procedure. But after the LAD was open and we have put the first stent, whenever the guiding catheter sits deep in the left main, we had a damped pressure and a reduced blood flow. And it was, we couldn't comprehend what was the reason, because, and it persisted during the last hour of the procedure. We had low blood pressure, although you can see we had a good flow from Lima, and we had a retrograde filling of Lima here. But the blood pressure decreased as the guiding catheter sits deep inside the left main. And the patient remained hypotensive with inotropic support for 1 week, and as you can see, it's still admitted in the hospital. It's a very fresh case here. I've just bring it here to share it with you. The other case is pretty the same in terms of doing the granuloplasty. It's
Can I ask a question?
Yes, please.
You know, with the first case, it's amazing that you managed to get to the LAD. In fairness, this is a very complex case. The only thing, why didn't you just stent the Lima to LAD?
We thought by passing the wire in this severely calcified and critically stenosed anastomosis site, the flow of the Lima to LAD will decrease and the patient would become unstable.
Sorry.
And if we couldn't manage to open the artery well and the balloons didn't work, we had no idea of balloon. We were prepared for rotablation, we were prepared for everything, but we thought if we couldn't manage to reach our balloons to the stenosed area of the Lima, maybe we don't have enough time to treat the patient, and she became unstable during the procedure. It was the main
concern.
Yeah, concern.
I mean, I've done few lemurs to LAD, and they're actually quite robust when you do the angioplasty. They're not as they can take a lot of things anyway. And the other things, I think, I don't know if the panel will agree with me. I think the hypotension sometimes happens on the reversal of the flow. If you do it sometimes when you open the native and the graft is failing. I have seen few cases where they go and get an ACS following your procedure, even if they have come elective. Sometimes because the collateral flow reversal phenomena type of ischemia.
It was the thing we couldn't comprehend what was the reason of the hypotension. Yes, yes. The ejection fraction was the same. No precardial effusion. No I don't think so. Yeah, yeah. Not a major side branch here. You can see the final results here.
You have no diagonal, so some maybe in subintimal, there is no diagonals at all the way to where the is.
Yeah, we can see the first images to see if diagonals were present in the first place or not. We have injection here. This is it. Oh no. This is the injection from the left radial axis to the via lima. You can see there are no diagonals here. A lot of septals, but yeah. We have septals, but the numbers decreased. Yeah, yeah. We have lost a couple of them. Yeah.
The reversal of the flow.
Yes.
Actually causes the ischemia.
Yeah, that could be the. Yeah. Yeah. 2 weak septals. We have lost them because of the reversal of the flow, as Dr. Ahmed said, not because of, I guess.
Can I ask a question?
Yes, please. Yeah.
Some people don't like to stent across the lima anastomotic site, and they use drug-eluting balloon. What's your take? Okay. Some people don't really like to stent into the lima anastomotic site and use drug-eluting balloon. I just want to know the experience with it.
Yes, she's right. We are hesitant to stent anastomosis sites. In my experience, the restenosis rate is very high, and that's why we go for the native vessel with the risk of restenosis being very high.
Yeah, the problem is that was also calcified. So you need to have a perfect result for drug-eluting balloon. So most of the time you will have some dissection or something. So you need to stent.
Your question was about the drug-eluting balloons or the stenting?
Yes. Or stenting at the anastomotic part.
Yeah. For the distal vessel, I guess the DEB was a good option for us. And in the final image, we have minimal dissection, which is a good thing to deliver the drug on the balloon. I think because the TIMI flow is free, it's a good thing to have a very micro dissection at the end of the vessel.
Good.
Yeah. Mm-hmm. We had rotablator in the place, but we thought we have prepared the vessel very well with cutting balloons, and we didn't want to, prolong the procedure further. It was already a prolonged procedure. If there are not other questions, I go for the second case. It was one of my friends doing this case. It was a 69-year-old male with a history of PCI on LAD 10 years ago with his CTO. He was referred to him to do the PCI on LAD, the stent thrombosis. He managed to go inside the stenosed artery with Gaia 2, and he passes a Corsair, and then there are 2 BMW wires inside LAD, and he has started the predilation. And when he tried to put the stent with the help of body wires, this is what happened. In the left angiogram, you can see, I don't know if it is evident here, he pushed the Orsiro stent through the LAD, and he was trying to pull back the BMW to prevent it from being jailed there. And he said, I felt a little resistance pulling back the BMW. And when he came out, for some reason, he lost his first BMW as well. And as you can see, there is a lost stent in the middle of the LAD, which was partially, I'm not sure it's evident here. Yeah. It's lost here, and the proximal portion is semi-inflated. And that was when he called for help, and I was in the cath lab next by. I went there to help him. We managed to wire through the lost stent again, and we started to aggressively predilate the stent. And as we were predilating the stent, you can see here our balloon ruptured, and the rupture caused one of the septal branch to perforate. Yeah. And we did the balloon tamponade several times, and somehow we managed to put another stent in the middle AD, and we terminated the procedure with this result. And we used protamine to reverse heparin, and we came out. After 25 minutes, the patient became hypotensive, and this was the angiogram after 25 minutes, and we did the precardiosynthesis, and this is the covered stent. We put the covered stent, and after 30 minutes, again, he became hypotensive. Yeah, this was LAD, but we had collateral flow from RCA. It was feeding the ruptured artery. Yeah. Very bad luck. Oh, this is what we did. We go inside the very small branch feeding the ruptured collateral, and as you can see here, does anybody have any idea what we did here? Yeah. I will show you here. Yeah. This is a method we frequently use in distal perforations. And
could you explain?
Yes.
Please.
This is somehow a novel technique, but previously others have used it. For guide wire-induced distal coronary perforations, we have published it in JACC in 2022. We snip one of the used balloons we had, and we put the snipped balloon from the over the wire segment, and we put another balloon behind the snipped balloon and push it through the area of perforation, and we leave it there. And we have done more than 10 cases like this, and with no problem. It's pretty fast. You don't have to look for clots or fat to embolize, or you don't need coils. Somehow, it sometimes works. It's it's for the lazy people. You know, in Shiraz, people are famous for being lazy, and it's the method of treating perforation for lazy people. Excuse me. For all the cases, we could manage to stop the bleeding by this method, but it depends on the size of the vessel you are treating actually, and the importance of it, because you are occluding the vessel totally, and sometimes coils are better options, sometimes fatter is a better option, but it's a fast option to stop bleeding. It doesn't matter. You can use, yeah, you can use the used balloons for the patients. You have a lot of used balloons there. You just snip it from the first, radio opaque area, or in this case, we snip it from the second radio opaque area. And with the first balloon, the bleeding continued, and we used the second balloon. And the final case is an RCA CTO here. It is the second attempt on this CTO. And as you can see, we had the problem of support here, but there is a very good conus branch proximal to the RCA. So we use the balloon anchoring system and use the ELONG. And the interesting thing was, we first started with 6 French guiding catheter, and the micro catheter, the ELONG micro catheter, passes easily. And when we exchanged our wire and tried to pass balloons, everything was lost. And after that, we changed for the 7th French catheter and used the balloon anchoring technique to pass our balloons and stents. And the reason I'm sharing it is that ELONG microcatheter passes pretty easily without this support, but every balloon we try to pass with this support, we couldn't pass it. We were obliged to exchange for a 7th guiding catheter and do the anchoring balloon technique to be able to pass it. And this is the final result, as you can see. And it was a disease distal RCA. Thank you very much.
I've got 2 questions. First is about the first case. How many of us would wire a graft which is reasonably flowing? This graft was not totally knocked out, but subsequently post PTCA to LAD, you could see a retrograde filling of the Lima graft. We don't know that Lima still could be the reason of her ischemia and hypotension. So would you consider closing Lima in this case? And second, regarding the second case, we can use a cut end of any of the wires pushed through a microcatheter that will also seal your distal perforations. So you can cut the distal black end of the wire, tip of the wire, and we can embolize that. That is pretty easy to do. I think balloon is little messy and it is difficult to control. You can really mess up in the mid segment of a big vessel, and then it will be very difficult to retrieve your balloon. If at all the whole assembly kicks back. I suppose you are pushing this cut end on the wire, and then you are pushing that thing with the second balloon. But what happens if you lose the access of the wire and wire pulls back because of lack of support or something? Then you are in a big mess actually. So otherwise you can pass a micro into that branch and push a small, a distal cut end of a wire or something like that. That would be much easier and much more controllable in this case. Regarding this Lima, I would like the expert's opinion. How much of us would close the graft after this kind of PCI, and how many of us would leave this alone like what you did in this case? Thank you.
For Lima, it's a little frightening to go for occlusion of the Lima, because Lima is an artery, and during the time with competitive flow, it itself maybe collapse. For SVGs, we have done the occlusion many times, but for Lima, I had myself no experience of occluding Lima after opening the main artery. I let to others.
Personally, I I don't close the lemma. If the lemma is small, it will involve by itself. Okay. If it's a large one, it's not a real steel like saphenous graft, because when you are in a saphenous graft, it means it's not in LAD. It's more in obtuse marginal branch or PDA. So it's a small vessel, and you have a large graft. So we know that here it could be not good for the native coronary to let the graft free. So then I will close this. But for the lemma, I think it's totally different. Okay, so
In this particular case, he said patient was hypotensive for 7 consecutive days post this. We can attribute that to loss of septals and diagonals. But one reason would be steel, one, whatever blood flow was coming anticately, part of it would be stolen by the lemma.
yeah, but don't forget that the flow is going also antegradely from the lemma to the LAD. So you have a competitive flow, but the flow is not going from the LAD up to the lemma. So it's not right because it's an arterial flow. So I think that the flow is going also from lemma to LAD, and you have some backflow, but small backflow in 1-2 centimeter, but it's not going up so. Because the real pressure of injection of the contrast is not the same of the pressure of the physiological perfusion. Because you know, if you inject the contrast, the pressure is more than the pressure in the lemma. But if we don't inject, the pressure in the lemma still always sometimes also more than in the LAD. It's why Alex told you that if you let lemma open, it will continue to do the perfusion from the lemma to the LAD. And I don't know if you have experience, maybe at a time if the situation will be occluded again, the LAD could be a solution. Maybe. I don't know if you have experience.
I think you have to also be careful because the flow from the lemma into the LAD is very important. And if you try to close it and you fail, you will close the LAD. Yes. That's what's going to happen. Your native LAD will be gone because whatever occlusion device, if you don't occlude it properly, it will migrate into the LAD and then you have a bigger problem.
But through the stent, why should a device migrate into the LAD? We have a stent which is
well, you have the stent has to come across. You're right. The stent has to come across. Yeah, in this patient, but
so that's where it was.
in this patient, yes, you can, but in others,
There, then I agree
yeah,
with what you are telling. But
yeah.
here we had a stent which was covering the.
Personally, I don't think there is any data. I don't know, Alex. You could remind if there is any data to compare. If the patency of lemma angioplasty is far better than the SVG graft. So in a case like this, personally, I would have fixed lemma to LAD rather than going into the native. But it depends on the quality of the lemma. If the lemma is bad, then you may consider something else.
And I think IVUS in first case would have given us a lot of clues about the wire being subintimal or whether it was true. What was the cause of occlusion? Most likely it is some way it has gone subintimal.
Yeah, but we don't care if the wire gets subintimal.
No, because the septals and diagonals, the septals are closed. So
yeah, but one is closed, but maybe it's closed because of the stent, of the stent strut, or because he went subintimal. Okay, but the final result was good. So it's amazing because I think, as you told, the way to treat and going from the left main to this LAD was much more difficult than going through the lemma. And the result was very, very good. So I think also it's because one of the septal disappear. And I have one bad experience like this where the same, I'm opening a LED, I was very happy, and I lose a large septal, and the patient went very bad. He was more symptomatic after I opened the LED than before, because I lost this big septal branch. So we sometimes underestimate the power of this septal branch, and it's a poor coronary tree. So I think each branches for this patient was important.
Yes, and the real fear for me going through Lima was the patient's hemodynamic status during the procedure, because we don't have.
Yeah, for sure. Because if the lima is spasm because of the wire or the guide wire, and there is no flow to the LED. So sometimes it happens when the lima is very tortuous. You go with a worker's guide wire, and then everything was a spasm, and it's not good also. Huh?
This patient's lima was everything. Yeah? We didn't have impediment to.
But you had an lesion LCX, and this lesion LC was patent, and we have maybe the LVF was at 145, and
no, but I'm very happy that you treat this patient and not me.
no, it's impressive.
Thank you very much.
Thanks.